injectable versus oral semaglutide. In India, there is no injectable semaglutide available, but in terms of weight reduction, injectable is better than the oral, as well as the HbA1c reduction. You know that it is in all the clinical trial, and we have the CVOT outcomes. The injectable was CV protective, and the oral is CV safety. And there are a lot of controversy regarding the what part of the CV safety was like whether it has injectable and the oral is different from each other. So the overall the injectable scores over the oral. The oral is the reason is the oral is oral because injectable has to be taken in injection, painful. So in terms of CV safety, if that point is taken care of, the rest of the things, the oral is probably most suitable for Indian scenario. The second most important thing is about the CVOT trial also. The duration is very small. You can see 1.3 where events occurred very early. So ideally to have a CV outcome trials, the longer the duration, we give a proper picture of it. That is the sole trial which is going on for this semaglutide probably will answer that.
More data for injectable as of now? I think you should start with a smaller dose. That's the main crux. Start with 3 mg and then slowly build up the dose. I think then they tolerate it better.
Because most of the patient who takes sema is affordable. It's not about most of the time it is affordability. It is most of the time GI intolerance.
No, even any of the GLPs, if you take it any alpha GLP, the dosing is always like you can injectable liraglutide also. Start with the 0.6, then 1.2, then it is 1.8. So it is the lower the dose we start it. As long the patient tolerate the lower dosage, then only we shift to the 7. Then becomes a 14. If the patient do not tolerate at 14, we keep 7 only. And whatever the benefit he gets from the 7, we continue that. Okay.
Also, the other thing we can do is actually when we explain the patient that the first week you might have some nausea and fullness kind of feeling, but it usually goes off by 7 days or 10 days, then the acceptance is better because we have already explained.
And how I convince our patient also, I tell them, see, nausea is better for you because you get a nausea and you will not feel like eating. So tolerate that nausea for 1 week. So most of the time they tolerate it and tell my weight will reduce. That is the more focus for me. So they will tolerate that nausea. And I tell this nausea is the first things which will help in starting reduction of weight. If you tolerate after 1 week, probably you will get adjusted.
Patient with
probably lean diabetes, there is no much benefit in terms of weight reduction. But even in lean diabetes, for example, Indian scenario, because the lean are not really lean because they have metabolically they are obese. Even at the diagnosis, we say around 25% of the lean diabetes are metabolically obese. They have a visceral fat. The advantage always remains for the metabolically obese lean diabetes also. So for a weight reduction, overall weight reduction, probably lean may appears to look like have a more lean mass weight loss. So there is no contraindication for giving lean diabetes patients.
I think we have to rule out pancreatic diabetes if they're really lean. Otherwise, I think we can use the molecule. It is still
CKD patients, up to what eGFR they will tolerate this semaglutide?
It is safe across all GFRs, sir, but only like I said, if they have GI already nausea and all, then we are probably concerned. And also if they are very much in a catabolic state with the significant weight loss, there's no there's no guidelines like that, but maybe we should be cautious in those patients. Yeah.
In sarcopenic obesity, will you recommend this one?
Yes, sir, because specifically it shows reduction in visceral fat. When you saw the data, it talks about specifically reduction in visceral fat, so it would be helpful in that. Of course, you should also have to advise protein intake and exercise, including the muscle.
Yes, absolutely.
Practically, with the combination of metformin and SGLT2 inhibitors, we see good weight reduction and also HbA1c reduction. So with cost effectiveness, how do you compare the combination of SGLT2 inhibitors and metformin with the semaglutide?
Sir, I said there was one of the studies were done, that is oral semaglutide versus SGLT2 inhibitors with a background metformin therapy, which has shown the better reduction of weight compared to this combination, the SGLT2 inhibitors plus metformin versus metformin with GLP-1 analogs. So in terms of weight reduction also it scores over even with those combinations.
The cost
Of course, that's cost is always a matter. So it cannot be like it's not affordable. The cost is more than 350 rupees, then a matter. So when it is only about 3 to 4 kgs difference or 1 or 2 kgs difference, probably it's not better to switch over to this medication. Second important thing is actually the cost benefit. When it comes to a cost benefit, the side effect when it talks about the SGLT2 inhibitors. So you can switch over to, if they are affordable, from SGLT2 inhibitors to GLP.
Yeah, I think one of the common in the place where I've used is that patients who have developed infections with SGLT2 and they've had lost weight and have regained. At that time, they are looking for something which help them to lose weight. And then the acceptance of this therapy becomes better. Even if the cost is high, they would still accept. So that's one easy way of introducing the drug in some of our patients for the benefits what we see.
More we use it, probably the cost may come down over a period of time. That is it.
Thank you, speakers, for an enlightening talk. We now request our chairperson, Dr. Sunil Kumar, to hand over a token of gratitude to our speakers. We would like to thank our chairpersons for presiding over the sessions and keeping the discussion electric. We request Dr. Sudeep K to hand over a memento to our esteemed chairpersons.
Inaugural function. As Aristotle once said, a task well begun is half done. Now, with a sense of enthusiasm and anticipation, let us proceed to officially inaugurate the function. We call upon our chief guest, Dr. Joe George, Dr. Sudeep K, Organizing Chairman, Dr. Ganesh H.K., Organizing Secretary, and Dr. Sri Krishna Acharya, Treasurer, to preside to the stage.
We request Dr. Sharadi, first year postgraduate, Department of Medicine, AJIMS, to invoke God's blessing with a prayer song.
Lambodara Lakumikara Lambodara Lakumikara Ambasuta Amaravinuta Lambodara Lakumikara Shri Gananatha Sindhuravarna Karuna Sagara Karivadana Lambodara Lakumikara Siddhacharana Gana Sevita Siddhi Vinayaka Teye Namo Namo Lambodara Lakumikara Sakala Vidya Adi Pujita Sarottama Teye Namo Namo Lambodara Lakumikara Ambasuta Amara Vinuta Lambodara Lakumikara. Thank you.
Thank you, Dr. Sharadi.
We now request dignitaries on the stage to light the lamp.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य.
We now request Dr. Sudeep, Organizing Chairman, to welcome the gathering.
Good morning, everybody. It's my pleasure to give the welcome address for this August gathering. As you all are aware, and as you have all been seeing from today morning, we are having a very excellent academic session. And for this, it has been possible to do this because of the enthusiasm shown by the ENDODIAB Charitable Trust. For this, I would like to thank and also welcome Dr. Joe George, who is the person behind this ENDODIAB Charitable Trust. Welcome, Dr. Joe George. I would like to welcome all the speakers who have taken efforts to travel all from different parts of our country to have come overnight and ready to give the talks for the day. I'd like to point out that this is the second chapter of the ENDODIABCON. Previous year, we had the first one, the inaugural one. The inaugural program 1 year ago was purely for the popularity of Dr. Ganesh only. Ganesh, your popularity has not come down. This time, it's not only on Ganesh popularity, it was the popularity of the previous academic session which has brought the crowd. And I'd like to proudly tell you that all the speakers, just initially one call was given and they all agreed to be a part of this program. And it is a very great achievement. And also we can see from the number of registrations what we are having here and the way the academic sessions have been programmed. So this kudos should go to Ganesh for the efforts he has taken over many months, over the last few months. I would also like to thank and welcome the chairpersons who have come here and have readily agreed to be a part of this program. And the input given by them is very useful for us and gives us more encouragement to conduct similar programs. I would like to welcome all the delegates who have taken enthusiasm to be part of this session and learn here. I would also request you to be more interactive with the speakers. I'd like to welcome one and all, and I hope we will have a very great academic feast till the end of the session today. Thank you very much.
Request our chief guest, Dr. Joe George, to welcome address the gathering.
Thank you very much, all delegates who have gathered here for this conference. I am so happy for Dr. Ganesh and his team, Krishna, Sudeep, who have done excellent job, not just in building the institution of ENDODIAB in Mangalore, but also making it the top endocrine and diabetes center in Mangalore. and that couldn't have been done without support of all physicians and doctors in Mangalore who have great trust in each and every doctors who are there in the ENDODIAB clinic, and to expand the view and to spread the awareness and increase the knowledge of the general population and the physicians and doctors who are practicing in Mangalore about endocrinology and diabetes. We have started ENDODIABCON last year in Mangalore, and this is the second edition, and I'm very happy and glad to see that it has grown to a regular event and would continue to grow, and I hope that it would continue to grow in the next few years. Thank you very much.
Thank you, sir. We are now handing over the certificates for winners of e-poster session held today morning. We request Dr. Joe George to hand over the certificates. First prize, Dr. Harini Jairam. Second prize, Dr. Vineet Kumar Sahu. Third prize, Dr. Venkata Subbareddy. Dr. Harini is a DM endocrine resident in AJ Institute of Medical Science. Dr. Vineet Kumar is KMC Manipal, and Dr. Venkata Subbareddy is from KMC Manipal. We would also request to hand over a certificate of appreciation for judges of e-poster competition. Dr. Sahana Shetty. I request Dr. Ganesh HK sir to hand over certificate. Dr. H.S. Asha and Dr. Saumik Goswami. Dr. Saumik Goswami. We request Dr. Sri Krishna Acharya to express few words of gratitude.
Good morning, everybody. From the ENDODIAB group, I would like to thank all our speakers who has come from all the way from Delhi, Mumbai, Kerala, Bangalore. So they have taken their time and participated in this CME. I also thank all our chairpersons who have come here as chairpersons, and few will be coming. I will thank all of them. And I also thank all the delegates who have come all the way and participated in our CME. So I also thank the audiovisual group Udupa and his team, and also thank TMFI group and the Ocean Pearl. So and also thank the pharma company. Because of their support we are able to conduct this. Now I will call upon the pharma company. They should come and accept token of appreciation, and I will ask Dr. Ganesh to give token of appreciation. Novo Nordics, one person from each group. Nobody is there. Novo Nordics. USV. Sun Pharma, Microlabs, Lupin, Pfizer, Lupin, Lupin, Lupin. Pfizer, Glenmark, Eris, Torrent, Pharma, Intus, Sardia, Merck, Sanofi, thank you. Abbott, thank you.
Without any further ado, we would like to begin our next session, that is Diabetes Management Practical Aspects. We would like to call upon our chairpersons, Dr. Sadanand Nayak, Senior Physician, Alva Health Center, Mudubitre, Karnataka. Dr. Sidney D'Souza, Professor and Head of Department General Medicine, Yenepoya Medical College. Dr. Prashant Y.M., Department of General Medicine, Father Muller, Mangalore, to grace the stage and chair the session. We now call upon our next speaker, Dr. Soumik Goswami, to talk on steroid-induced diabetes management. We now hand over the session to the chairpersons.
I hope people are busy having their small snack. Should we wait for 5 minutes or should we continue?
As you wish.
Okay, if we are getting late, I think we'll continue. They'll join us. I think we have a problem with steroid-induced diabetes. I think we have about 10% of the inpatients who are at, for one cause or other, are being put on steroids. That especially is more so in internal medicine and rheumatology clinics and inpatients. And most of our patients are diabetic as well because they have so many comorbid conditions. And steroids are known to change the diabetic status. And this is where do we require to use oral or injections in the form of insulin, or just a diet control is a million-dollar question. To answer these questions, we have Dr. Soumik Goswami, who is MD and DM in endocrinology. He is a faculty in the Department of Endocrinology, NRS Medical College, Kolkata. Treasurer, Endocrine Society of Bengal. He has about 83 publications in peer-reviewed journals. He won the BC Roy Memorial Award in 2005. And with all this introduction, you have a real good task of telling the audience what do we need to do with people with steroid-induced diabetes. Over to you, Dr.
Thank you, sir.
Soumik Goswami.
Thank you, sir. A very good morning to all of you. And glucocorticoids are not actually very bad, because if we look at our evolutionary history for hundreds and millions of years, the stress response mediated via glucocorticoids have helped vertebrates from fish to mammals, all of us survive. We are here today because of glucocorticoids. And for the last 7 decades, they are working wonderfully in treating a variety of conditions. But like you were mentioning, every rose has its thorn. So diabetes is one of the consequences of use of glucocorticoids in even in physiologic doses, or more so if you are using a supraphysiologic dose. So we'll first clear some basic concepts before going into the topic proper. So there could be 2 terms coming up: steroid-induced diabetes, steroid-induced hyperglycemia. So someone who has absolutely normal blood glucose goes up after giving steroids is steroid-induced diabetes. Whereas steroid-induced hyperglycemia is a broader term where even in pre-existing diabetes, if you give steroid, blood glucose goes up further. In normal individuals, you give steroid, blood glucose goes up. And we know that we have been taught in our pharmacology classes that there are some dose equivalents of steroid, like 20 milligrams of hydrocortisone is equal to about 5 milligrams of prednisolone, which is equal to about 0.75 milligrams of dexamethasone. Now, this needs to be kept in mind, because whenever we talk of increasing or decreasing the dose of steroid and the drugs that we are using to treat hyperglycemia, these equivalences come into play. However, I would like to give out the caveat that these equivalences are based on the immunomodulating effect of steroid and not on the glucose increasing level of steroid, but we will use them interchangeably. Another concept which needs to be kept in mind before going into the topic is the duration of action of the steroids, because the blood glucose increase often mirrors the duration of action of steroids. So hydrocortisone starts going up in about 3 hours, acts for about 6 hours. So the blood glucose will follow the same pattern. If you look at prednisolone, methylprednisolone, they start going up after about 8 hours and they persist for 12 to 16 hours. Longer acting glucocorticoids like dexamethasone go up more gradually, act over 24 hours. Now, if we look at these 3 images and if we look at how the insulins which we use, their duration of action, interestingly, if you look at hydrocortisone, it's almost like a short-acting insulin, the level of hydrocortisone and the action of short-acting insulin. If you look at prednisolone, it's like NPH insulin, 12 to 16 hours. And if you look at dexamethasone, it's like a longer-acting insulin, like insulin glargine or insulin degludec. And this concept will help us later when we talk about how to manage hyperglycemia with the use of these glucocorticoids. Now, how big is the problem? As our chairperson sir was telling, the problem is huge because a lot of people across the world are on glucocorticoids for one reason or the other. And they might contribute to as much as 2% of new diabetes globally. You just look at the huge number of diabetes, 2% of that could be because of glucocorticoids alone. If you follow patients on glucocorticoids over a period of a year, 1 out of 3 will develop hyperglycemia, 1 out of 5 will develop diabetes, which means there was no diabetes previously. Now there is diabetes in 1 out of 5 on glucocorticoids for a year's time. In inpatients, the rates are even higher, but all this is an underestimation because in a lot of these studies, only fasting glucose was looked into. Now, if you use a glucocorticoid in the morning, particularly a short-acting or an intermediate-acting one, the fasting glucose might be absolutely normal. It is only the postprandial values which are high, and again during the night time it comes down again. Who are the people who develop most of this hyperglycemia? Again, it depends on the dose of the glucocorticoid. The higher the dose, the more the risk. It depends on the mode of therapy. Intra-articular, oral glucocorticoids, intralesional, they have a higher rates of hyperglycemia. Elderly have a higher rate of hyperglycemia. Those patients who fit into the metabolic syndrome phenotype, they have higher rates of hyperglycemia. Smokers have higher rates of hyperglycemia. And if you are on concomitant medications like tacrolimus or mycophenolate, because these are often used as a part of immunomodulating regimes, or even diuretics, the rates of hyperglycemia are higher. Now it is said that if you cannot measure it, you cannot change it. So first we should know how to measure it. So every patient before being put on a glucocorticoid should have their blood glucose estimation done to find whether there is pre-existing diabetes or not. And a glycated hemoglobin as a single test is a good enough test to detect pre-existing diabetes before giving glucocorticoids. Now, once you have started glucocorticoids in patients without diabetes or in patients with diabetes, the best time to measure blood glucose would be in the post-lunch or the pre-dinner or the post-dinner phase, because that is when the glucose will actually start going up. Now, how frequent should you measure it? So in an inpatient where glucocorticoid is initiated, if you know that this patient has diabetes to begin with, it should be at least 4 times daily, focusing mainly on the afternoon to evening period. In someone who does not have diabetes, you are initiating it for the first time, it should be once daily, again in that afternoon to evening window. Now in someone who does not have diabetes, you start measuring glucose once daily and you find that it's absolutely normal over 3 days time. You can stop measuring glucose, but again you need clinical discretion. If it is on the higher side, close to say 200 milligrams per deciliter, it would be good to continue till the time of discharge. Now in someone who does not have diabetes to begin with, you initiate monitoring once daily. But now you find that the glucose levels are persistently above 200 milligrams per deciliter. In that case, you need to increase it to 4 times daily. So pre-existing diabetes, 4 times daily, not known to have diabetes, once daily, increase to 4 times daily. If it goes into the diabetes range, you can stop monitoring after 3 days if it is normal. In an outpatient setting, in those without pre-existing diabetes or even in those with pre-existing diabetes, it should be a minimum of twice weekly, twice every week, and more frequent if the levels are high. Now it's important to realize that those in an outpatient setting on long-term glucocorticoids might not develop diabetes within the first week. They might develop in the second, third or fourth week, as has been seen from the data. But again, having said all that, less than 1 in 3 individuals have their glucose monitored to see whether they have diabetes or not before giving steroids, and only about half receive monitoring after giving steroids. So the numbers speak pretty poorly of our expertise, of our practice. So the message here is that if you give someone glucocorticoids, rule out pre-existing diabetes and monitor frequently, particularly in that afternoon to evening period over the first few weeks of therapy. Now, can we use non-insulin therapy to control steroid-induced diabetes? Yes, in some cases. Like someone who does not have pre-existing diabetes now comes with steroid-induced hyperglycemia or steroid-induced diabetes, and the fasting is still less than 200 milligrams per deciliter, you can consider using an oral therapy initially. Now, if you use a sulfonylurea like glimepiride, it acts over 24 hours and might cause nocturnal hypoglycemia because the glucose is mainly high in that afternoon to evening period. So shorter acting sulfonylureas like gliclazide, like glipizide have a role to play here. Gliclazide, the immediate release version, you can begin it with 40 milligrams per day, gradually increase to up to 240 milligrams before breakfast to control postprandial hyperglycemia.